So an overview of what we're going to talk about today. So we're hosting a multidisciplinary presentation on obesity management in severe asthma. Each speaker will present on a different topic to provide multiple insights and approaches for obesity management. And at the end of each session, we'll have time for a group discussion on how to best integrate these approaches. If you do have burning questions and there's time, we'll allow questions after each presentation as well. So today we'll be hearing from Professor Lisa Wood, who'll provide an overview of this area, Dr. Hayley Scott, who'll be providing a dietetics perspective, Costa Karihalu, who'll be providing a bariatric surgery perspective, Dr. Katie Wynn, who'll be providing an endocrinology perspective, and Dr. Ben Britton, who'll be providing a clinical psychology perspective. So without further ado, I'd like to introduce Professor Lisa Wood. Lisa Wood is a biomedical scientist and registered nutritionist who leads the nutrition research team at Healthy Lungs and Healthy Life program at NHMRC. Her research focuses on nutritional approaches to managing inflammation, and her particular interest is in mechanisms of obesity in respiratory diseases. Thank you, Lisa.
So that's the microphone for the webinar.
Yeah. Got there eventually.
Thanks, Vanessa, and thanks to the Severe Asthma CRE for the opportunity to talk today. I've titled my talk Obesity, Inflammation and Chronic Disease. We're going to look a bit of general information on that. I want to give some specific examples because, of course, most of us in the room are very interested in asthma, so I'm going to give some specific examples in the asthma area as well. So just an outline, we're going to talk about globesity, a term that's now used to describe the... This way? Oh, okay. Sorry, hi out there. We're going to talk about obesity and chronic disease risk, and then obesogenic diets. We're going to look at the role of adipose tissue and its development during obesity, dietary fat, and then also fruit and vegetables. Why do I have that little thing on my slides? There we go. Okay, so this chart here I think is quite interesting, and if you go to the WHO website, you can actually see the shift in obesity over time from 1975 to 2016. You can go through it year by year, frame by frame. So I've just taken the two extremes. In 1975, this is the world map colour-coded according to obesity. And just to really focus on what we're looking at, on this map, any colours, any countries that are coloured in a shade of blue have obesity prevalence over 20%. And you can see in 1975, there were no countries who had obesity prevalence over 20%. By 2016, the majority of the world is blue. The majority of the world has obesity rates over 20%. In America, it was 36%, but there's just recently been some more information come out that says 39% of Americans are obese. And in Australia, the prevalence is around 28%. So it certainly is a global epidemic. This chart here shows us, it's Australian data, and it shows the shift in BMI over time. And you can see that this dotted blue line represents 1995. And at that point in time, distribution of BMI was fairly normally distributed, with the mean around 25. And over the last 10, 15 years, that has shifted. So now we've got a lot more people who've moved into this obese range. But why do we care? Like, who cares if we are becoming more obese? Well, essentially, it's because it increases mortality risk. And this has been known for decades, but we still haven't really been able to address the problem. It's known that if you're a BMI of 20 to 25, you have a very low mortality risk. This increases as body mass index increases, so that when you become as high as a BMI of 40, you've got more than a twofold mortality risk compared to somebody who's in the normal weight range. So many diseases are linked to obesity, This diagram lists some of them. So pulmonary disease, cardiovascular disease, diabetes, pancreatitis, gallbladder disease. Just about every organ in the body is affected by obesity. And it's these diseases and conditions that increase mortality risk. This data is from the Australian Bureau of Statistics, and it looks at people who have chronic disease in Australia and what are the common characteristics of those individuals. So 95% of people who have chronic disease have an inadequate fruit and vegetable consumption, 56% are inactive, 63% are overweight or obese. And you can see in the middle there's a lot of overlap between those poor lifestyle factors. The other thing that's common about people with chronic disease is inflammation. So systemic inflammation is an underlying mechanism of all of those diseases that we've just described. Now, obviously, those diseases are very different. The pathology of those diseases is very different. So the way that systemic inflammation contributes to those diseases is different. So, for example, in cardiovascular disease, systemic inflammation causes macrophages in the arterial wall to become hyperactive. That leads to the development of foam cells and atherosclerotic plaques. So for cardiovascular disease, that is a key mechanism. Now, obviously, that's different to what's happening in cancer or asthma, but systemic inflammation in each of those diseases, there's a key pathology that's leading to, that's causing those diseases to either develop or progress. So I want to focus today on obesogenic diets and how they are actually fueling that systemic inflammation that we know is underlying all of those diseases. Most people would have seen the Australian Guide to Healthy Eating. It's very simply described as a plate, and that plate has the 5 food groups that we need to consume, and the size of the piece of pie is the proportion of our diet that should be made up by each of those foods. So you've got grains, you've got vegetables, you've got fruit, you've got dairy, you've got lean protein. So each of those food groups needs to be consumed to comprise a healthy diet, because each of those food groups represents unique, there's obviously overlap, but there's also unique ingredients that are provided by each of those food groups. Down in the bottom corner, you can see a collection of foods that you probably wouldn't describe as healthy. So it's alcohol, soft drinks, fast foods, confectionery. Now, these foods are what we call discretionary foods, and they're called discretionary because they don't need to be consumed in the diet. If you never ate any of those foods, you would have a completely balanced, healthy diet. They can be consumed within a healthy diet, but they're not providing any nutritional value. The problem is they provide a huge amount of energy. And the other problem is that in the Australian diet, 35% of our energy comes from those foods. So this really creates a big problem. Just if you're interested, that's a list of the top ranking discretionary foods: cakes, muffins, scones, pastries, wine, beer, soft drinks. No surprise there. You can see for yourself, you can understand why those foods would be considered to be discretionary. So they provide high energy content, which is a real problem for obesity because obviously it leads to excess energy intake. The other thing is that they change the quality of the diet because you substitute them for healthy foods. So if you're filling up on cakes, muffins and scones, you're not eating fruit and vegetables, you're not eating whole grains. And so it really does change diet quality. And we actually know in terms of fruit and vegetables, only 93% of adults get the recommended intake of vegetables of 5 serves per day. Fruit's a bit better. 50% of people eat the 2 serves of fruit that's recommended. But in terms of vegetables, we do really poorly. So the result of that is that we've turned healthy eating on its head. This is another way of describing a healthy diet. There's a number of different tools that are used. This is the food pyramid. This might have been around when you're in high school. But essentially down the bottom of the pyramid, it shows foods that should be eaten in large quantities, so fruits, vegetables, grains. And then up the top, it's got foods that should be eaten in small amounts, fats, oils, salt. We've turned that upside down. And so we're consuming far too many of the wrong foods. The result is excess adipose tissue, which is essentially what we're talking about when we say the word obesity, a high fat intake and the wrong types of fats, low antioxidant, low fibre intake. So I'm just going to talk about each of those now and describe why that's a problem, how they are contributing to this systemic inflammation that we know is underlying chronic disease. So first of all, adipose tissue. So we need adipose tissue. It's an essential part of the body because that's where we store fats for energy when they're needed. And in a healthy person, their adipose tissue looks like this. There's adipocytes. In amongst those adipocytes, there's some immune cells, some macrophages. They're anti-inflammatory in phenotype of the M2 phenotype. And the reason I'm focusing on this is I'm going to show you some data that we've collected that relates to this in a moment. With weight gain, those adipocytes become engorged with triglycerides. They swell, they become stressed, and they start to release pro-inflammatory mediators. We call them adipokines. The other thing that happens is those immune cells that are in that adipose tissue become activated and they change in phenotype to an M1 phenotype. And that M1 phenotype of macrophage releases lots of pro-inflammatory mediators. You also get the development of what is called a crown-like structure. So on that figure there, this is a necrotic adipocyte. That adipocyte is dying and the debris is picked up by those macrophages. It fuels the macrophages and further activates them. And the result is this low-grade chronic inflammation that's present 24 hours a day, 7 days a week in obese individuals. Inflammation isn't supposed to be chronic and persistent. Inflammation is supposed to be something that's transient, that resolves a problem and then is removed. In the case of obesity, there's no resolution because the adipose tissue is still there. And that's why we have the development of chronic disease. So I wanted to show some data, and Costa's been involved in collecting this data. This is a paper that was published by Hashim Perialil as part of his PhD. And in this particular work, we've been working with bariatric surgeons, including Costa, who's going to speak later today, as well as Tim Wright. Now, this is a photo that I took actually during one of Tim's surgeries. And what he is doing, as he's performing the bariatric surgery, he's collecting a sample of visceral adipose tissue for us. And then we're bringing that back to the lab and studying it to really understand this phenomena of obesity-induced inflammation. This is a slide from one of the samples that was collected, and I really like this slide because you can actually visually see what I've just shown you in a sketch on the previous chart. This is a tissue of a slice of adipose tissue and it's been stained for macrophages. So the macrophages are there in the red, and you can see this is one of those crown-like structures that I've just described. And it's important in asthma because the work that Hashim has shown is that if you take samples from obese asthmatics and compare them to obese controls, you have an increased proportion of those M1 macrophages, which is on that first slide. That proportion of M1 macrophages is inversely correlated with lung function. So the more of those M1 macrophages, the worse your lung function. And then if you also divide up the asthmatics, according to their severity of disease, those with the most severe disease have the highest levels of M1 macrophages. So it's more than just a theory, it's actually important in a clinical setting. Now, I'm not going to talk about weight loss today because Hayley's going to cover that in the next talk. But I did want to flag that we actually know the solution to this in one sense. We know that if people with asthma lose weight, then their asthma improves. And Hayley did a lot of work with this in her PhD, and there's actually a number of studies that have shown this consistent effect that if you can reverse the problem, if you can get obese asthmatics to lose weight, then their asthma control improves, as well as various other markers in these different studies. There's different techniques that can be used. There's lifestyle interventions, there's pharmacotherapy, there's bariatric surgery, and they're introduced with increasing stages of obesity. It doesn't matter what strategy is used, that will improve asthma. And Hayley, as I said, will focus more on that in the next talk. Okay, so now I wanted to move on to dietary fat as another component of obesogenic diet, which is, has pro-inflammatory actions. Now, of course, not all fat is the same. So the types of fat, there's saturated fat, trans fatty acids, they're well known to be pro-inflammatory. There's other types of fats that are protective or anti-inflammatory, particularly omega-3 fatty acids. Also, monounsaturated fats have been shown to have various health benefits. But I want to focus on saturated fat because I'm talking about the bad guy today. So here we've got a picture. This is an immune cell. And on the surface of immune cells, you have receptors. The one that we're interested in relation to saturated fat is the toll-like 4 receptor. There are other receptors that interact with saturated fat, the nod-like receptors, for example, but in particular, most of the work is focused on toll-4 in relation to saturated fat. Now, the fascinating thing is, and this is only a discovery that in terms of science, it's a relatively new discovery, that saturated fat activates the toll-like 4 receptor in exactly the same way as bacteria. So we've known for decades that toll-4 is protective against bacteria, and if bacteria is present, immune cells will interact with that bacteria. The bacteria will bind to toll-4, induce an inflammatory response, and that's how the bacteria is dealt with. But now we know that in exactly the same way, saturated fat binds to that toll-like 4 receptor and initiates an inflammatory response. So if you have a chronically high saturated fat diet, if you're an obese individual who has impaired lipid metabolism, who has chronically high elevated levels of free fatty acids, then you have chronic activation of this mechanism, which can then lead to negative outcomes. So we actually looked at this in asthma because the work that has been done in the rest of the field is all focusing on different diseases. And a lot of the work around obesity, for obvious reasons, comes out of the cardiovascular literature. But we wanted to know if this actually had anything to do with what happens in the lungs. So we did a study and we took adult asthmatics, we challenged them with a fast food meal or a control meal. So the fast food meal was 2 breakfast burgers and 2 hash browns, and the low-fat meal was a tub of, the control meal was a tub of low-fat yogurt. Now, I understand before you start putting up your hand and say, well, that's not just about fat. Well, it's not. So there's lots of differences between these meals. And we started with this point at this point because we wanted to understand if we put the most extreme contrast that we could think of, would it cause differences in inflammatory response? And so this was the data that we collected. We measured after people consumed those meals, and then we monitored their airway inflammation for 4 hours afterwards and their lung function. And we found that after 4 hours after the fast food meal, there was an increase in neutrophils, an increase in toll-4 expression, which confirmed that mechanism. And we also found this interesting result with bronchodilator response. So people had been withholding their medications before they came into the clinic. They came in, they consumed the study meal and were given a bronchodilator. And we found that people who consumed the control meal had an increase in their lung function at 2, 3, and 4 hours, as you would expect. And for people who had the fast food meal, they had an initial increase in their bronchodilator response, but then their lung function fell down at 3 and 4 hours back to baseline levels. So we've seen this really fascinating result of increased airway inflammation and an impairment in the efficacy of the beta-2 agonist after 4 hours of a single meal of eating like that. So you can imagine that chronically eating like that, it potentially has very significant implications. Now, I haven't got time to talk about it today. Since then, just this year, we've published a follow-up study for this, where we've actually looked at isolated macronutrients, looked at saturated fat versus polyunsaturated fat versus carbohydrate, and examined the changes that occur with those specific nutrients. And we have confirmed that it certainly is saturated fat that's inducing these responses. There's a paper published in JACI a couple of months ago if you're interested in reading that. Okay, so lastly, I want to talk about fruit and vegetables because they are one of my favourite things and are so important when you're talking about obesogenic diets because, as we've already discussed, they tend to be, in some diets, eliminated. In the case of people who prefer discretionary foods, it's really fruit and vegetables that are sacrificed. So, of course, there's hundreds of nutrients in fruit and vegetables. So in some ways it makes it challenging to study fruit and vegetables. But there's two aspects of fruit and vegetable content that I want to focus on. So one is antioxidants. So there's a whole range of phytochemicals that you find in fruit and vegetables that have antioxidant properties. And there's thousands of articles in the literature that demonstrate that things like vitamin C, carotenoids, flavonoids, polyphenols have anti-inflammatory actions. The other nutrient I want to focus on is soluble fibre because that's a nutrient that, again, in terms of scientific literature, it's relatively new, the idea that soluble fibre could have anti-inflammatory actions. So the anti-inflammatory actions of soluble fibre focus on the digestion products of soluble fibre. So anything that's fibre, by definition, it isn't digested until it reaches the bowel. So soluble fibre, when it reaches the bowel, is partially or in some cases completely digested to form short-chain fatty acids. Now, those short-chain fatty acids, there's two key pathways that have been best described in terms of how they can induce an anti-inflammatory response. One is activation of free fatty acid receptors, GPR41-43. The other is inhibition of histone deacetylases. It doesn't matter which pathway you're talking about. Either of those pathways will lead to a suppression of NF-kappa B, which is the master controller of inflammation. So if you suppress NF-kappa B, that has downstream anti-inflammatory actions. So again, I just want to show you two studies that we've done in asthma, which look at this concept of fruit and vegetables as being anti-inflammatory. So the first study is published a few years ago now. It's a 3-month trial where we had asthmatics randomised to a high fruit and vegetable diet or a low fruit and vegetable diet. The high fruit and vegetable diet was dietary guidelines, so 5 serves of vegetables and 2 serves of fruit. So it wasn't really high, it was really recommended. The low fruit and vegetable diet was less than 2 serves of vegetables and less than 1 serve of fruit per day. So that is actually the median Australian intake. So we're comparing recommendations versus actual Australian intakes. And we found a couple of things. When people went onto the low fruit and vegetable diet, their systemic inflammation increased. So their plasma CRP increased. There was also an indication that airway inflammation was increasing with sputum total cell count increased after that 3-month period. Probably most interesting was the effect on risk of asthma exacerbations. So this is a survival curve that shows time to exacerbation. The top line here, the black line is the high fruit and vegetable diet. The dotted line below is the low fruit and vegetable diet. And there was a significant difference in time to exacerbation. So people who went onto the low fruit and vegetable diet were 2.3 times more likely to have an asthma exacerbation in that 3-month period. The last example I want to give you, again, of just really highlighting why an obesogenic diet is unhelpful, has negative effects on health outcomes. This is another study in asthmatic adults, and it's a 3-way crossover trial. In this study, we just took soluble fibre. So rather than supplementing with fruit and vegetables, because again, there's such a mix of nutrients. When you use fruit and vegetables, you can't be certain what particular nutrient is having an effect. So in this study, we used isolated soluble fibre supplement. So this was an inulin supplement. Inulin is found from a whole range of strange combination of fruit and vegetables. So chicory root, bananas, asparagus, all sorts of nutrients. But you can buy it as a supplement, and then it's just taken with water. And in this study, we had 3 different arms to the study. We used inulin plus a prebiotic, and we used a placebo. And when people took that supplement for 7 days, and then we looked at what happened in terms of their clinical outcomes as well as their airway inflammation. And these are the key results. Rebecca's been working on this for years, but so I've just picked out the key results to show you today. So we found that following inulin supplementation, there was a decrease in asthma control. So that's an improvement in asthma control. And interestingly, people who had poor asthma control at baseline actually had 100% of them had an improvement in their ACQ. There was a decrease in eosinophils. There was an improvement in HDAC9, and I chose to put that up because, again, it confirms the mechanism that we know from the literature is modified by short-chain fatty acids. And then we saw that the people who had the lowest HDAC9 expression, they had the lowest eosinophil levels. So, again, all tying together towards that mechanism of short-chain fatty acids. So just to summarise, obesity prevalence has reached epidemic proportions. I'm not telling anyone anything new there. Chronic inflammation, which is caused by obesity, is a common pathology for many comorbidities such as asthma. And so obesogenic diets become very interesting because they are actually driving that inflammation, and as well as driving the production of adipose tissue, they're also causing diet quality to be decreased. So we know there's certain solutions. We're not very good at implementing that, but we know that reducing fast food intake is helpful because it reduces saturated fat intake. We know high fruit and vegetable diets are helpful because they provide antioxidants and soluble fibre. And we know that achieving and maintaining a healthy weight is helpful. And there I'm going to segue to Hayley because she's going to talk about strategies for maintaining and achieving a healthy weight.
Thank you, Lisa. In the interest of time, we'll hold over your questions until the end of the session. So now it is my pleasure to introduce Dr. Hayley Scott. Dr. Hayley Scott is a postdoctoral research fellow at the Centre for Healthy Lungs at the University of Newcastle. Hayley's research aims to better understand the roles of obesity, nutrition and exercise in promoting or impeding inflammation, and ultimately the effect this has on pathogenesis and treatment of respiratory diseases. Maybe that's the dodgy. Go into that screen. Hide that mouse. Thank you, Hayley.
Thanks, Vanessa. So obesity and asthma are known to be associated, but the ideal management approach is not well understood, which really limits our ability to translate this into clinical practice. So in today's presentation, I will talk about the consequences of obesity and asthma and also talk about studies that examine its management. I'll also talk about factors that predict weight loss success, and I'll close with a summary and recommendations. So obese individuals are twice as likely to develop asthma. Obese asthmatics have poor lung function and asthma control, and also more frequent exacerbations and hospitalizations for their asthma as well. So this suggests that they have a more severe asthma pattern. They're also resistant to inhaled corticosteroid medication, which is the mainstay of asthma pharmacotherapy. A number of studies have sought to determine, the effect of obesity on clinical asthma outcomes. And this is a study published in JACI back in 2008. And as you can see, obese individuals on the left had a significant impairment in their asthma-related quality of life. And this level of impairment was at the level of being clinically significant. Similarly, the obese individuals were also nearly twice as likely to have needed oral corticosteroids in the last month, and were also more than twice as likely to have been hospitalised for their asthma in the last year, compared with people who were both normal weight and overweight. The prevalence of obesity in asthma is alarmingly high, particularly in severe asthma. So 27% of Australians are obese, but this is increased in asthma to 36%. The prevalence is further increased again in severe asthmatics, with an Australian study citing a prevalence of 45% in those prescribed Xolair. So that's nearly half of all patients prescribed Xolair are obese, which is pretty shocking, really. So it's clearly a problem, but what should we do about it? Should we work on improving the quality of the diet? Should we work on increasing their exercise levels? Or weight loss in general, is that enough to improve their asthma? So a few studies have looked at different components, and for example, the studies that have looked at diet quality. So obese people are more likely to consume a diet that is high in fat, a diet that is low in fruits and vegetables, and also a diet that is pro-inflammatory. And each of these factors have been associated with asthma that is more severe. So this suggests that they could potentially be targeted as part of obesity management. So in terms of dietary fat, fat intake has been shown to be higher in people with severe asthma compared with those with mild to moderate asthma. As Lisa mentioned, it's associated with increased airway inflammation and impaired bronchodilator responses. So this suggests that it could be targeted to help manage asthma in people who are obese. Low fruit and vegetable diet, also common in people who are obese. And again, an intervention study has shown that a low fruit and vegetable diet doubles the risk of experiencing an asthma exacerbation and also is associated with reductions in lung function. And another study has shown that it is associated with increased airway inflammation. A study published in 2013 also found that consumption of raw vegetables, so more than 5 handfuls per week, is associated with better controlled asthma. And the authors hypothesised that this was due to the antioxidant effects of the vegetables. So now on to a pro-inflammatory diet. We have a new tool called the Dietary Inflammatory Index, or the DII, and we can use this tool to grade nutrients and food items from anti-inflammatory to pro-inflammatory. We can therefore score an individual's diet according to their specific intake of these nutrients. And it's been associated with a range of different diseases. So for example, obesity, cardiovascular disease and mortality are all associated with the DII. And also in asthma, Lisa's found that people with asthma actually have a higher DII diet as well. And within people with asthma, a higher DII diet is associated with poorer lung function as well as systemic inflammation. However, to date, there's been no studies in adults with asthma that specifically manipulate the DII, so we need to do a lot more research in this area to see if it can be used as a potential management strategy for obese asthmatics. So I guess the obvious approach to managing obesity in asthma is weight loss. However, there's only been 5 randomised studies conducted internationally, which really limits our ability to understand what the best approach would be. We conducted one of these studies where we compared a dietary intervention, an exercise intervention, and a combined dietary and exercise intervention. So the dietary intervention was a low-energy diet where participants consumed 2 meal replacements per day, as well as a third healthy main meal and snacks. They attended weekly dietetic counselling sessions with me, which were conducted either face-to-face or over the telephone. For the exercise intervention, participants attended a personal training session once per week and also completed another 2 training sessions per week in their own time. They were also encouraged to increase their daily steps by 10% per week to a target of 10,000 steps per day. The combined intervention was a combination of both the dietary and exercise interventions completed at the same time. So this slide shows our body composition results. And as you can see in the figure on the top left, the dietary and combined interventions were quite efficacious in producing weight loss. So we saw an average of 8% body weight loss within a 10-week period. The exercise intervention, about a 2% weight loss that wasn't statistically significant. Similar patterns with our other outcomes, so waist circumference on the top right and fat mass on the bottom left. where the dietary and combined interventions were more efficacious in producing reductions in these outcomes as well. This was an expected outcome because it is easier to create a calorie deficit through dietary restriction than what it is through increasing exercise levels, so we weren't surprised with that. But we did also obviously look at clinical asthma outcomes, and the two outcomes that we primarily focused on were asthma-related quality of life, which you can see on the left, and asthma control, which basically looks at asthma symptoms in the week prior to their visit. And what we did was we looked at the proportion of participants who had clinically important improvements in each of these outcomes. So these are indicated by the black fill in each of these bars. So as you can see in the figure on the left, more than 80% of participants who lost between 5 to 10% of their body weight had a clinically important improvement in their asthma-related quality of life. Similarly, as you can see on the right, nearly 60% of patients who lost between 5 to 10% of their body weight had a clinically important improvement in asthma-related quality of life. Interestingly, what we found in participants who lost more than 10% of their body weight, there was no additional benefit in terms of the proportion of participants experiencing improvements. So I'm just going to run through a couple more studies that have been published. So this one's a very low energy diet that was published in the BMJ in 2000. And for this particular study, they used 3 meal replacements per day to achieve the very low energy diet. And they found participants lost 14.5% of their body weight in a 12-week period. And interestingly, these participants maintained an 11.3% weight loss at the 12-month follow-up. So just briefly touching on some of the results they looked at, an interesting one was their lung function changes. They looked at FEV1 up the top and FVC down the bottom, and both of these outcomes were significantly improved in the intervention group compared with control, and these improvements were maintained at 12 months, which is quite a good outcome. So this next study is a more recent one. It was published in 2015, and it was quite a large study, 330 participants, so the largest study that's been published in obesity management in people with asthma. They compared a reduced energy diet where they encouraged healthy eating along with 150 minutes of moderate intensity exercise per week. And the authors were aiming for a 7 to 10% weight loss, which they measured at 6 months and 12 months. The data in this table is the 6-month outcomes, and as you can see, the participants unfortunately didn't meet the target weight loss. It was around a 5% weight loss that was achieved, whereas the control group achieved a 1% weight loss. And this resulted in no significant differences in any of the outcomes. So asthma control, asthma-related quality of life, or lung function didn't actually differ between the intervention group or the control group. However, when the authors looked at the participants who lost at least 10% of their body weight, they actually found that these participants were almost 4 times as likely to achieve clinically significant improvements in their asthma control compared with those who remained weight stable. So what that suggests is that the overall cohort just didn't lose a sufficient amount of weight for them to achieve clinical improvements in their asthma outcomes, and more weight loss was needed. This 4th study is quite an interesting one. It's probably the most recent one. It was published last year in the Blue Journal. And what the authors did for this one was they compared dietary restriction with the combination of dietary restriction and exercise for 3 months. And the reason that they did this was because they wanted to see if the addition of exercise to your traditional dietary induced weight loss augmented the benefits that they would receive in terms of both body composition and asthma outcomes. And the study did show that the combined intervention was a better approach. So this slide here shows the body composition changes, and as you can see in the figure on the top left, the white bar represents the dietary restriction group only, whereas the grey bar represents the combined group. So there was more than twice as much weight loss in the combined dietary and exercise group. Fat mass also as shown on the top right, and visceral fat mass, again, improvements were better in the combined group compared with the diet alone group. And interestingly, you can see on the bottom left, there was a loss of muscle mass in the diet only group, whereas the addition of exercise resulted in a maintenance of this muscle mass. So, and it actually a trend towards an increase. So this suggests that the combination of dietary restriction with the addition of exercise is superior for the management of obesity in terms of body composition changes. They also looked at clinical asthma outcomes. So the top two figures show asthma control, so symptoms in the last week, and the bottom two figures show asthma-related quality of life. So the figure on the top left shows that asthma control wasn't actually improved with dietary restriction alone. However, with the addition of exercise, there was a significant improvement in asthma control score. Similarly, with the asthma-related quality of life, both groups did improve their asthma-related quality of life. However, again, it was the combined group, so the diet plus exercise performed much better than just the diet alone. So these authors also looked at the percentage of subjects that experienced clinically important improvements in each of these outcomes. So again, similarly to our figures, the black fill represents the proportion of subjects who had clinically important improvements in each of these outcomes. And as you can see in both these figures, the addition of exercise almost doubled the proportion of participants who were experiencing clinically important improvements in their asthma outcomes compared with dietary restriction alone. So the authors also looked at FeNO, which is a indirect measure of airway inflammation. And they looked at the diet group alone on the left and the combined group on the right. And so basically the dietary group had no change in their airway inflammation, whilst the combined group had a significant reduction in their FeNO, so their airway inflammation. So it went from about 30 parts per billion down to 20 parts per billion. So this is suggesting that exercise was needed in combination with the diet to specifically target the airway inflammation in this cohort. And this is supported by other studies that examine exercise training in people with asthma. So this is some data that we published in 2013 where we saw a significant reduction in sputum eosinophils following 10 weeks of exercise training. So before training, sputum eosinophils were 3%, and then following training, they dropped down to 1%. So this suggests that exercise is an effective approach for managing airway inflammation. So just a little bit about exercise. Exercise levels are lower in people with asthma, and they're also lower in people who are obese. So it's highly likely that obese asthmatics have a very low exercise level, and it's also highly likely that this is making their asthma more severe. So definitely a systematic review has found that exercise training improves asthma-related quality of life by 17%, FEV1 by 3%, and also provides an additional 9 symptom-free days per month. While another study has shown that people who are physically active are 2.5 times more likely to have well-controlled asthma. The mechanism isn't quite clear, but it does appear that it does target airway inflammation, so it's possible it's through these means. So I thought I'd just change directions just for my last slide and talk about factors that predict weight loss success in people with asthma, because obviously this is important for translating into the clinical setting. So this is some data we published a few years ago now from the weight loss study that we have published in the past. And what we found was that our participants that had poorer lung function at baseline actually lost more weight than the participants who had better lung function. We were surprised to hear that the participants had better lung function. So if you look at this figure on the left, participants who had more airway obstruction actually had a greater percentage weight loss, and they also had a greater percentage fat loss. In addition, we also found patients that had a poor asthma-related quality of life did better. So for every 1 unit decrease in their baseline asthma-related quality of life score, they lost 1.7% more weight. We also found that people who had uncontrolled asthma, so that was defined as an ACQ score of at least 1.5, they lost twice as much weight as people who had well-controlled or partially controlled asthma. We hypothesised that this might be due to a greater motivation for people to lose weight with severe asthma in an attempt to try and better control their disease. So we looked at other factors as well, and we found that men, not surprisingly, lost more weight than women, so they lost an additional 3.6 kilos. And we also looked at eating behaviours, and we found in women, those who reduced their uncontrolled eating lost more weight. So uncontrolled eating being subjective feelings of hunger accompanied by a loss of control over food intake. Men, on the other hand, those who increased their cognitive restraint performed better. So cognitive restraint being a conscious restriction of food intake in order to lose or control weight. So these are all things that can be targeted in the clinical setting. So for example, with severe asthmatics, it could be potentially a really motivating factor to encourage weight loss. And then these eating behaviours could be targeted as well by clinicians. So just a little summary of today's presentation. The evidence is limited, but it does appear that we should recommend to our patients that a modest 5 to 10% weight loss might improve their asthma. So we've seen clinically important improvements in both asthma control and asthma-related quality of life with this degree of weight loss. They could also be advised that a poor quality diet may be making their asthma worse. So the evidence suggests that a high-fat diet is associated with more severe asthma, as well as suppression of bronchodilator responses. A low fruit and vegetable diet is associated with poorer lung function and also twice the risk of experiencing an asthma exacerbation. Well, a pro-inflammatory diet seems to be associated with poorer lung function and systemic inflammation, but we do need to do more research on that. Additionally, exercise does seem to be quite important in this population because it does target airway inflammation, whereas with dietary restriction, we aren't actually able to target inflammation. It doesn't appear to be having any effect on that. It does also appear to have more favourable effects on body composition and asthma outcomes. So it should definitely be encouraged as part of obesity management. And finally, more severe asthma surprisingly does appear to be associated with greater weight loss, and we believe that it's possibly due to a greater motivation to lose weight in an attempt to improve asthma. Thank you.
Thank you, Hayley. Again, in the interest of time, we'll hold over your questions till the end. So it is now my pleasure to introduce Dr. Costa Karihalu. Costa completed his medical training at the University of Sydney, and his surgical training was based in the Hunter region. He's been performing advanced bariatric surgery for over 10 years and is keen and committed to the lifelong follow-up of his bariatric surgical patients and ongoing research into the improvement to optimise quality patient outcomes. Thank you.
Thanks. Thanks very much for asking me to speak. I really enjoy coming to these sort of meetings because I always feel like I learn a lot more than I actually teach. And, you know, whenever you get the surgeon up, it always feels a little bit like the panel beater at, you know, a classic car show where, you know, you smash them, we fix them. I don't really care about how we got to this situation, but surgery is the answer. So anyway, here goes. So who should consider surgery? I think we're all familiar with the criteria of people with a BMI of greater than 35 with significant comorbidities. But in our population, I think the acceptance is of people with a metabolic syndrome, and there's perhaps less of an uptake in people with severe asthma. In fact, in all the years of doing bariatric surgery, I can't actually recall a single referral for management of their treatment refractory asthma. Obviously, end-stage organ failure is a contraindication for surgery, and no unstable medical or psychiatric comorbidities, although the stability of psychiatric comorbidities is a little bit of a fluid concept. But most importantly, in surgery, we try to deal with patient expectations, and having a patient who's realistic and committed to the idea of lifelong follow-up is essential if you're going to have a good long-term outcome. How does that translate into the numbers of the obesity epidemic who are actually getting surgery? Well, if we look at the obese population, 50% are actually unaware of the fact that they've got a problem, and 30% are aware, but they're not interested in surgery in any circumstances. And there's about 15 to 20% who are actually contemplating surgery or in the process of going through that. And that's industry data, so we know it's true. Currently, it's less than 1% of the population who would qualify for surgery actually get surgery. So in surgical teaching, Isbister was a great educationalist, and he had the idea that when you became a surgeon, it takes about 2 years to learn how to operate. It takes 5 years to learn when to operate, and you spend the rest of your career learning when not to operate. And that's sort of the phase that I'm in. So there are certain measures of obesity and classifications and staging. The Edmonton Obesity Staging System tries to measure medical, mental and functional deficit. and ranging from mild, moderate, severe, and irreversible end stage. And unfortunately, what we were finding, especially when we had the public bariatric clinic here, was that it was only when people were in stage 4, or almost we'd put a stage 5 in there as well, where they were on home oxygen and in a wheelchair, that some bright spark would think maybe they need a bariatric operation. And unfortunately, those people are always disappointed. And really it's stage 2 and stage 3 obesity where we're looking at moderate to severe comorbidities and the onset of end organ dysfunction that we get best long-term results with surgery. The concept of prehabilitation is an important one when we look at chronic disease, and it's a bit of a buzzword in surgery at the moment, where we discuss improving function leading into surgery in order to improve our outcomes. And certainly in the settings of metabolic syndrome or asthma, we spend quite a bit of time optimizing medical management. And we do pay lip service to the idea of preoperative exercise programs, and there is some ongoing research with upper GI surgery in the John Hunter looking at CPEX testing and some structured exercise programs there. But I really don't think we have a very good handle on implementing exercise programs in our preoperative patients. Mechanical, and here I actually mean physically improving our space intraoperatively by shrinking the liver size. And OptiFast, which is a very low calorie meal replacement diet, and actually no better than any of the other ones, but it's sort of cornered the market in terms of the published research. It's been shown that a 2-week course of this very low calorie meal replacement can reduce the size of the liver by anything up to 15%, which from a surgical point of view, where you're operating at the hiatus, that makes access a lot better and surgery a lot safer. Psychological prehabilitation starts with the realistic sort of setting of expectations, but also relates to expectations of surgery, that the absence of pain and the rapid mobilisation and rapid discharge from hospital. So I guess the message I want to get across is that this is low-risk surgery, even in relatively high-risk patients. We have a bariatric surgical registry which has now recruited over 85% of all operations performed in this country. So this is a field under intense scrutiny. And the mortality rate in the data from, not this year just published, the year before, was 5 out of 11,000 patients. So it's roughly it's less than 1 in 2,000, comparable to cholecystectomy figures. And so I often have patients who come in with a hip replacement and 2 knee replacements telling me that they're terrified of bariatric surgery. And you point out to them, well, actually, the mortality from your knee was 1 in 200 and your hip was 1 in 100, and you're worried about this 1 in 2,000 procedure. The readmission rate nationwide is about 2.5%. So we are achieving good benchmarks in that respect. But we can stratify our risk in terms of there's the labs data, which is longitudinal assessment of bariatric surgery, which comes out of the American database stuff. But obviously increasing age over 55 doubles your risk. Sex, where males have a roughly double risk of complication compared to females. Insulin requiring diabetes. Higher BMIs, so BMI over 50 and then over 60, and revisional surgery and each revision of the operation. And these things can all be factored into a model where we can predict pretty accurately what the risk of a perioperative event is going to be for a patient. How you actually use that risk data is a topic for another day. But let's deal with the elephant in the room. And the elephant in the room is that in the Hunter region, this is not widely available in the public sector. And there are huge discrepancies between states and between health services within those states in terms of access to publicly funded bariatric surgery. That is because in discussions with administrators and hospital managers, the very first thing that's brought up is that they love the idea of bariatric surgery, but they'd like you to make it cost neutral. Now, there is an extensive body of literature looking at the cost benefit of bariatric surgery, and it's actually one of the very few operations where you have a positive QALY at 2 years. So 2 years of surgery is not only paid for itself, but it's actually paying for reduced health costs for the rest of that individual's life. But that is very difficult to put on a piece of paper and relate to number of operations and the resourcing that we actually need to do this properly. But this is an ongoing discussion. The resources that I would consider would be a minimum would be a multidisciplinary approach to get all the interested specialists involved in presenting their patients. We need to have proper dietetic support. When the bariatric surgical program closed here 2 years ago, we had all of 0.2 of a bariatric dietitian. And these are patients who really do need a lot of time spent in terms of education and getting on board with what bariatric surgery entails. We need dedicated theatre access, and in the Hunter region, or in the John Hunter in particular, where the theatre utilisation runs at 99 to 102%, it's very difficult to find a dedicated operating theatre space. But more than anything, there needs to be a vocal and a publicly sympathetic patient cohort. Okay, so if we look at the way that certain groups have had public funding made available to them, it's through having a vocal and sympathetic patient cohort. And unfortunately, at the bariatric population, the morbidly obese population are still very socially discriminated against, and a lot of what we're seeing in the public sector is a demonstration of that discrimination. In a practical sense, the cost in New South Wales, Concord Hospital does run a program, so there are cases that we can refer down there. And in an even more practical sense, wink, wink, if somebody does have reflux, then they can have an anti-reflux operation, which is a Roux-en-Y gastric bypass, which just happens to work quite well for weight loss. And interestingly, administrators don't bat an eyelid at anti-reflux surgery being performed on morbidly obese patients. So just briefly, the surgeries, this is actually a historical slide because it's got the adjustable gastric band in there. That's an operation which is very much on the decline. I certainly haven't done one for about 8 years. The Roux-en-Y gastric bypass is sort of the most established operation with the longest track record. The sleeve gastrectomy is currently the most popular operation. The biliary pancreatic diversion with the duodenal switch is also an established operation. We'll just discuss those quickly. How do these operations work? The most important mechanism for weight loss after bariatric surgery is through restriction of the volume of food that can be taken in. There are operations that are almost purely restrictive, like the sleeve gastrectomy, which just involves removing about 80 to 90% of the gastric volume. The gastric bypass, although many people think, well, that's a bit malabsorptive because you bypass some intestines, you bypass between 1.5 and 2 metres of 9 metres of intestine. So the amount of malabsorption you actually create is minimal. And the bypass works mostly, again, by just restricting the volume of food that someone can eat, and also by inducing some dumping, which acts as a aversion therapy to taking high GI foods. Malabsorption got a very bad rap because of some social consequences. Malodorous stools and body odour can be a significant side effect of biliary pancreatic diversion and duodenal switch. But we only really see clinical malabsorption when you've reduced the size of the common channel, that is the amount of intestine where digestive juices and food admix, down to below 2 metres. And most of the malabsorptive operations we do now are really looking at trying to make that common channel 3 metres or more. But they're certainly bypassing 5 or 6 metres of the small bowel in order to reduce the quantity of caloric absorption from the food that's taken in. The interesting field that we're getting into is the concept of neurohumoral effects of surgery. And this is an interesting concept when we look at, I think Hayley was mentioning the cognitive restraint that people can show in controlling their dietary intake. And I think that reflects a Descartesian view of the world, which was where he said, I think, therefore I am, that, you know, the mind controls the gut. But increasingly we realised from a developmental point of view that when we crawled out of the primordial slime, we were a gut tube. Certain surgeons still are just a gut tube. And the brain evolved in response to hormonal influences from the gut. So these are amongst the most primitive drivers that we have for behaviour. So when someone says they really feel like something to eat, that's actually not coming from their brain, that's actually coming from gut hormones that are driving your need to eat. So we all got very excited about ghrelin, which was the hunger hormone, and we found that a lot of it was secreted by the fundus of the stomach, which is removed in a sleeve gastrectomy, and then we found that, well, actually, you know, ghrelin levels went down, and then they found that there were a few different moieties of ghrelin, and the ghrelin that worked in the hypothalamus actually didn't change at all. So like most hormones, the more we know, the more we realise we're pretty ignorant of it, but it's certainly an interesting field. The ileal brake mechanism is also, I think, best explained in a developmental sense, and that is that if you present undigested food to the ileum, so a long way downstream in the small bowel, that actually sets off a very powerful trigger to stop eating. As you can imagine, if you've eaten enough that you've got undigested food hitting the ileum, you're not going to eat anymore. And that's perhaps what we're doing when we introduce these malabsorptive type operations, such as the duodenal switch or the SADI, which stands for single anastomosis duodenal interposition, where we try and present food to the ileum a lot quicker after a meal. And perhaps they're the mechanisms by which we're seeing very promising results in terms of excess body weight loss. So there are a number of different surgical options, and this is registry data looking at the operations that are actually being performed, and the dominant one in Australia is the sleeve gastrectomy. And if you look at the performance of that operation, that number is going up and up. And so a year ago it was up at 66%. I think it's now pushing 70%. The gastric band is dwindling away. There's some small pockets of resistance in Victoria, but they'll be gone soon enough. The Roux-en-Y gastric bypass is pretty constant at about 10% of the operations that are done. And you see that reversal number sits at about 10%. And they are bands that are coming out or sleeves that are getting converted to a different type of operation for weight regain or for other issues. So this is the bariatric surgical community here. There's one guy going, there are actually other operations. No, it's a sleeve. And the paradox is 10 years ago, this is exactly what was said with the gastric band. You know, there's more than one operation for this. No, we want a band. And so we are sort of repeating the mistakes of the past. Although whether this is the bariatric surgeons or the bariatric patients, I'll leave that open. So what are the results of surgery? Well, unfortunately, we'll be a bit evasive here and say, well, what are your endpoints? And as a group, weight loss surgeons and bariatric surgeons have been a bit evasive on this because we can't agree. Is it weight loss? Well, if we're talking about excess body weight loss, we'll see with most of the operations and most of the published data, there's a sustained 50% of excess body weight loss. Is it the achievement of non-obese BMI? Well, then it starts to be a lot more difficult because that really depends upon where you start. And again, that comes down to your psychological prehabilitation, where somebody with a BMI of 60 is never going to achieve a BMI of less than 30 and maintain that. And they're going to cause themselves a lot of psychological and physical morbidity trying to achieve a goal which is completely unrealistic at the start. Okay. Whereas somebody with a BMI of 50 has got about a 5% chance of achieving a BMI of less than 30 with a sleeve gastrectomy alone. Somebody with a BMI of 40, different kettle of fish. You've got about a 40 to 50% chance of maintaining a BMI of less than 30. But are we really looking for comorbidity improvement and resolution? And we know that our best bang for buck, is what Haley showed, was with the first 5 to 10% of weight loss, and that's been shown with all metabolic illness. And in that case, do you really have to go reaching for bariatric surgery? No. But what we really want is patient satisfaction. And what patients really want is to be normal. They want to be able to sit in a chair. They don't want kids laughing at them. And unfortunately, in that last goal, often we fail to deliver, because surgery does leave people with excess skin and other consequences which may require further procedures, and so they end up in a surgical pathway. So the results from the Swedish obese subject study are probably the most rigorous long-term cohort, with 99.7% follow-up, and there are any number of other registries that you could look at in the United States and Australia. And we've got 25-year data for the gastric bypass, suggesting 25% of total body weight loss. So that's a 160 kilo patient who's 120 kilos. Okay, so they're not skinny, but they're certainly not 160 kilos. The sleeve data, we've got 11-year published data now, and we know that for most people it's a pretty good operation. So 50% of patients maintain 50% of excess body weight loss. But we are seeing this increasing rate of reflux, which I think, especially in the asthmatic population, is an interesting concept. And anything up to 12% of patients develop de novo Barrett's, suggesting significant acid exposure. So those lemmings are going to be dealing with a tsunami of sleeve revisional surgery, and that's probably going to be the next wave of operations that you are all hearing about. So putting bariatric surgery and asthma into Medline, it generated about 11 studies. And as you can imagine, with the Hawthorne effect, every single one of them said surgery was fantastic. So I don't, the references are there. Risk of asthma exacerbation after bariatric surgery in adults, that was a California-based database, sort of registry data, that ED visits reduced by half in the population who'd had surgery versus the asthmatic population who hadn't had surgery. Long-term improvements in pulmonary function 5 years after bariatric surgery. They measured the FEV1 and FVC and found that despite the natural aging of their population, they had about somewhere between 4 and 7% improvement in their FEV1 and FVC, I think, to a lesser degree. The effect of bariatric surgery on asthma control, lung function, bronchial and systemic inflammation. That was from 2015, and they found improvements in small airway function. You see, I'm talking about stuff I really don't know a hell of a lot about here. But they certainly looked at systemic inflammation, CRP levels, adiponectin, leptin, and they all reduced in the bariatric surgical group. And they reduced the mast cell numbers in their bronchial washing. And then there was a long-term study of weight loss induced by bariatric surgery on asthma control and health-related quality of life, which was a small pilot study. It was just a cohort control. There were 26 patients, 15 had a gastric band, 11 had medical therapy. And they found that the gastric band population over 5 years dropped their BMI from 44 to 29, improved their FEV1 from 84 to 89% of predicted, versus a reduction from 88 to 84% of predicted in the non-operator group. The asthma quality of life and asthma control indices all improved in the surgical group. And those were all significant. And I guess after what we've heard, not that surprising. So what is our practice? We practice the long run-up, which is taking time to optimise the patient, to prehabilitate the patient, to get all of the relevant physicians involved, give them time to see the dietitian and psychologist and engage in preoperative therapy, improve their physical activity levels. perform a gastroscopy to try and assess the severity of reflux disease, because someone who already has severe reflux, it would be foolish to put them through a sleeve gastrectomy when a gastric bypass is going to give you a better long-term outcome. And if they have a BMI over 40, put them onto a course of OptiFast, very low-calorie meal replacement for about 2 weeks prior to surgery. My current practice over the last 12 months, it's been about 70% sleeve gastrectomy, 30% raw and wide gastric bypass, and I've started doing single anastomosis duodenal interposition as a revision operation for weight regain after a sleeve gastrectomy. What I appreciate we could do better is a preoperative exercise regimen. And what do we do intraoperatively to try and improve their lung function? We use a very steep head-up position. So these are rapid operations. So gastric bypass might take 90 minutes, but a sleeve might be over in half an hour. The anaesthetist gives them a totally intravenous anaesthesia, so they're not getting inhalational agents, which can be bronchospastic. So that, and I think propofol can actually reduce the amount of inflammation. We max out on their antiemetics, so everybody's getting dexamethasone and ondansetron, as well as the Maxilon and cyclozine. We spare opiates as much as possible, and part of that is actually psychological prehabilitation. There's a big movement among anaesthetists now where if you're a surgeon, you tell a patient they're going to have post-operative pain, you're actually being negligent. You need to tell them you're not going to have any pain at all, and then you've prehabilitated them. I actually aerosolize some local anaesthetic, and that's been shown to reduce the amount of post-operative pain and ongoing shoulder pain. We don't give them a PCA, they just have a Panadol by infusion in the first 24 hours, and they have maybe 20% of them use endone for the first 24 hours. But fortunately, where we practice our surgery, we have a fairly liberal ICU admission policy, and that has been shown to improve our outcomes. Post-operatively, mobilise early, go home quickly, routinely use PPIs, avoid NSAIDs if at all possible. Prolonged thromboprophylaxis, DVT-PE risk in this high-risk group is a real thing. In just over 1,000 cases over 11 years, I've had 1 post-operative PE and 1 post-operative portal vein thrombosis. But again, could do better with a structured exercise program. So the take-home message is that surgery is a safe option for realistic and compliant patients. There's evidence of improvement in most comorbidities, including asthma, but surgery is not a panacea for the obesity epidemic, and surgery has never been a cure for a public health problem. But increasing rates of obesity surgery are going to see higher rates of revisional surgery because obesity is a chronic relapsing condition, and all surgeries carries long-term consequences.
Thank you, Costa, for another fantastic presentation. So next up we have Dr. Katie Wynn. Katie is a Senior Staff Specialist at the John Hunter Hospital in the HNE Health District. Her current clinical and research focus is on obesity and metabolic health, including the efficacy of a very low energy diet in severe complex obesity in people with obstructive sleep apnea. Thank you.
Thank you for the talk so far. I think hopefully I can tie a lot of those themes together with a slightly different slant from an endocrine perspective. Thank you. So we've seen that obesity is a risk factor for asthma and causes more severe disease with poorer outcomes. And perhaps for at least a subset or a phenotype of asthma, the endocrinology of obesity and metabolic health underlies some of the pathophysiology. So in the next 15 minutes, I'm going to look for the first half a little bit about how do we know when to eat and when to stop eating, and whether those metabolic signals of nutrition are linked to inflammation and what happens to them when you become obese. In the second half, I'm going to discuss how we can improve that metabolic stress And particularly as this is such an emerging field, have a look at some of the putative mechanisms from preclinical data and what the future may hold for novel targets for asthma. This is the Foresight obesity system map. You can see my pointer, and right in the middle of all this big web of factors that cause obesity is this little circle that's the homeostatic control of appetite and energy homeostasis. So although it's overwhelmed by all these factors, I think Ben will talk to us about psychology, and we've talked a little bit about food availability and the environment. This control mechanism is really crucial. And if we think about all the choices we make over the course of a year, all the food choices, all the choices about whether we go to the gym or not, in fact, for most people, we're amazingly able to control our body weight within about 0.5 to 1 kilo, which is per day about 10 to 20 calories, so very fine control. This control mechanism sits in the hypothalamus, and it's controlled by 2 populations of neurons that can integrate all our signals both from our adipose tissues and our gut tube that Costa discussed. This is so important that when it goes wrong, it really goes wrong. So it was only in 2012 that we discovered this group of kids with morbid obesity who had a defect in one of the set of neurons, the POMC neurons. And this makes them very, very hungry, very hyperphagic from the first few months of life. And you can see this is a growth chart of one of these kids, and they gain BMI very rapidly. So if we think about how those signals are integrated, firstly, as we've heard, there's signals that come from the adipose tissue, largely leptin and adiponectin, that are very good at signaling a calorie deficit or undernutrition, less good at signaling when we are overweight and obese. And there's a second group of perhaps shorter term signals that come from the gut. Costa's talked a little bit about ghrelin that comes from the gastric fundus and signals when you're ready to eat, so it's a hormone of hunger. Whereas from the L cells of the small intestine, there's a range of satiety peptides, which include GLP-1, which we'll come back to later as a potential management option, PYY, CCK, and oxyntomodulin. And they tend to be released after a meal, particularly in response to saturated fats, which is interesting. And they tell you that you've eaten, that you're full, and you can finish your meal. This doesn't occur in isolation, and I was pleased that you'd already talked about short-chain fatty acids, because certainly there is a relationship between gastrointestinal hormones and the release of short-chain fatty acids from the gut, which is coordinated by the microbiome. That relationship's not very clear because, as we've seen, high fiber diets tend to be high in acetate, which inhibits airway inflammation. But recent studies have shown that acetate can actually also be pro-obesogenic by acting on the brain to increase that hunger hormone ghrelin and increase insulin, which tells you then to store all that energy away in fat. So there is a very plausible and clear mechanism by which obesity and metabolic dysfunction can lead to some types of asthma. And we've seen from Lisa's presentation that the adipose tissue, particularly when it becomes harmful visceral pro-inflammatory fat, will directly release cytokines that promote asthma. As you become overweight, and the changes in the hormones are shown in the blue side, your leptin levels increase and adiponectin levels fall, and that employs those mechanisms to drive those pro-inflammatory changes. Likewise, there are also changes to gut hormones which occur during obesity. Ghrelin tends to inhibit those pro-inflammatory pathways, And in obesity, rather than ghrelin being high, which would have been a nice hypothesis that you had too much hunger hormone, actually ghrelin is low, both at baseline, but also after you've eaten, perhaps the natural fall in ghrelin is attenuated, which could contribute to hyperphagia. But that low level of ghrelin also drives pro-inflammatory pathways. GLP-1 is particularly interesting because there are so many different ways that it could be linked to asthma, some of which I've written here. And in obesity, the GLP-1 response to a meal, so normally it would peak and then fall and you would feel sated. That is low and inhibited in obesity. So there are several different ways that that could then lead to metabolic asthma. So coming on to management, we've talked about the thresholds at which weight loss might help asthma. And when we look at all the obesity-related health conditions, they're quite differently sensitive to weight loss. And you will see that down at the bottom, particularly the psychological complications of obesity are very resistant to weight loss. So perhaps you would be looking at bariatric surgery to help with these sorts of complications. But as Costa has pointed out, for metabolic and ventilatory complications of obesity, you usually only need quite a small change in your body weight in the region of around 10% to have benefit. Our local Australian guidelines, which have been written quite recently in 2006, have really changed the way we think about obesity-related health conditions, away from the thought that it's all about the number on the scale towards how we can improve metabolic and other types of obesity-related health conditions. And you will see, based on the available data, the target weight loss is now much more aggressive than it perhaps once was. And a very important factor is whether you have complications of disease, whether they be medical, psychological, or functional complications of just weighing a lot and wear and tear on joints and breathlessness. Asthma is not part of the guidelines, and I've added that on because I think it makes sense that it should be. We've got a lot of evidence now that it is one of the metabolic complications of obesity. And you can see the more complications that you have, the more the intensive interventions. And really the cornerstones are very low energy diets, pharmacotherapy, both of which I'll talk about, bariatric surgery, which Costa has spoken about, and exercise, which I've added on, which we've seen is really important as well. So certainly in the world of metabolic health and diabetes, there's been a huge paradigm shift from us telling our patients that type 2 diabetes is a chronic progressive disease. Your pancreas stops producing insulin and you're bound to need to have injections eventually. The Counterpoint study, starting in about 2016, really changed how we thought about it to a disease of ongoing positive calorie balance. So even for people who've had quite long-standing diabetes, if you can take the fat out of their liver and pancreas, and that's done very well with a very low energy diet, then you can actually restore their insulin secretion and remove their insulin resistance. And this might have very important applications for asthma, because we know, as we've heard, that metabolic syndrome and insulin resistance are very closely related with that certain phenotype of asthma. And there are good mechanistic links between those two things. Haley showed one study of very low energy diet in women with severe obesity that showed good improvement in outcomes. And I think we will see that this specific effect of very low energy diet on visceral fat will be a really useful therapeutic adjunct to give inflammatory benefit. We did a study over the last couple of years looking in the more complex patients to see if giving a very low energy diet, not in a clinical trial setting, but just as part of our routine outpatients, would be beneficial to metabolic health. And you can see we had a significant reduction in body weight and diabetes control and in diabetes remission, not dissimilar to the Counterpoint study. We did have 1 or 2 patients with asthma in that cohort whose asthma improved significantly, but we didn't follow that as an endpoint. And picking up on Costa's point about providing services locally, we did use this to write a business plan to run a metabolic clinic that could then select the appropriate patients for bariatric surgery, but it has as yet not been funded. So moving on to medication, there are actually very few medications that are TGA approved with a specific indication of obesity. And as yet, none of those are PBS approved, so they all cost quite a significant amount for the patient. I think the most interesting one from our perspective, thinking about asthma, is liraglutide. As you'll know, liraglutide is a long-acting form of GLP-1, so employs those GLP-1 signaling pathways, and it's marketed as Victoza for type 2 diabetes at a dose of 1.8 milligrams, and as Saxenda for obesity at a dose of 3 milligrams. And apart from the effect on weight, which is significant, about half of people will lose 5% of body weight over a 3-year period. More importantly, it has shown some positive effects on obesity-related health conditions, at least in the type 2 diabetes dose. In the LEADER study, there was a 13% reduction in MACE over that 3-year period. So it would be very interesting to see if it has the same effect on reducing the complications around asthma. The authors that wrote the LEADER study did do a sub-analysis on only, there were 9 patients in the study who had well-documented asthma who were non-smokers, and only 7 of those had been adherent to liraglutide over 52 weeks. But for what it's worth, those patients did show reduced symptoms and reduced exacerbations, shown over in this graph. And preclinical studies of the use of GLP-1 agonists have shown that they do help all those mechanisms that we've heard about to reduce inflammation. The other drug that might be of interest is the DPP-4 inhibitors. And just to remind you, if we have GLP-1, usually it's degraded by ubiquitous enzyme DPP-4 to inactive GLP-1, and we use DPP-4 inhibitors such as sitagliptin to inhibit that process and cause buildup of endogenous GLP-1. And there has been one study that has looked at the effect of sitagliptin and shown it does also reduce inflammation in asthma. So what about other metabolic medicines? If the link is between insulin resistance and asthma, then potentially drugs that reduce insulin resistance could be helpful. And there have been some studies of metformin that show that at least in Taiwanese patients, you're less likely to be admitted to hospital and less likely to have an exacerbation if you're on metformin. Pioglitazone is a PPAR gamma activator, and the PPAR gamma, once activated, influences genes that control lipid and glucose metabolism as well as inflammation. And quite a large cohort study has shown that there is reduced new incidence of asthma and the reduced use of inhaled and oral corticosteroids in people on pioglitazone. However, a small study hadn't shown any effect on people with existing poorly controlled asthma. Ghrelin we heard about when we were talking about gastrointestinal hormones, and the low levels of ghrelin and obesity certainly drive that inflammatory response. But unfortunately, if we did try and give ghrelin as an intervention, you would increase hunger and be likely to precipitate further obesity. And as yet, there are no effective ghrelin inhibitors for obesity or agonists that we can give to determine their effect on asthma or inflammation. So in summary, it's very difficult at the moment with the existing research to tell what is cause and what is effect, but there is certainly a plausible mechanism that links gastrointestinal hormones as well as adipokines to asthma. And future research really needs to focus on pulling out the different phenotypes, because all obesity is not the same, as all asthma is not the same. I think asthma should be a component of metabolic syndrome, and we should be considering the intensive treatments, so very low energy diet, metabolic surgery to treat the cause. A significant subset of patients with asthma have concurrent diabetes. So the existing diabetes treatments that are out there, GLP-1, the DPP-4s and metformin, may be very apposite treatments, and perhaps it would influence your choice of medication for those patients. Thank you very much.
Thank you very much for another interesting presentation. It's now my pleasure to introduce our final speaker today, who's Dr. Ben Britton. He's a senior clinical and health psychologist who's worked with patients with chronic disease for over 15 years. Ben's research interests include clinical behaviour change in both patients and clinicians with difficult to treat populations. Thank you, Ben.
Thank you. Hi guys. Hi internet followers. Steve asked me to come and talk today, basically to present on the role of the psychologist. He pretty much said, psychologists, who needs them? And so hopefully we can kind of answer that. It's obviously a very broad aspect of any kind of chronic disease, and in particular obesity, the psychology involved. So it's going to be a kind of broad talk. If you have specific questions, maybe it's better to do them in a panel sort of situation. But hopefully I can give you just some clinical things to maybe think about. So psychologists, why are we involved? Well, the first reason, the first answer is because mental illness is very, very common. This photo shows how your medication will be delivered if you go to one of the nice private mental health facilities in Sydney. They come on special leaves. But it is. That's the first reason why psychologists really should be involved in any sort of chronic disease, chronic illness, and indeed obesity management. So I've just got some prevalences about mental illness. So in the Australian population, the lifetime prevalence of mental illness is about 45%. So it's pretty high, just about 1 in 2. So a 12-month period prevalence, it's about 20%. So in any 12-month period, so this year, 20% of the population are going to have a diagnosable mental illness. In the asthma population, it's even higher. So about 60% of people with diagnosed asthma are going to have sometime in their lifetime a diagnosable mental illness. And once again, in that period prevalence, it's about 35%. So obviously studies vary once you start doing comorbidity studies, but that tends to be about where the numbers are falling. Then if we look at obesity, we have some interesting figures. So people who are obese, about 40% of them in a point prevalence, so any point in time, about 40% of people with a diagnosis of obesity will have a mental health problem or could be diagnosed with a mental health problem. But it's also bidirectional. So point prevalence of obesity in patients who have mental illness is up around 60%. So you can see there's a lot of overlap across both asthma and obesity and mental illness, and they're all going to interact. The directions and the ways they interact is complex, but they're highly related. Does that surprise to anyone? No. Asthma gang, you would know that, right? Yep. So if we look at mental illness and obesity and some potential mechanisms on the way mental illness can affect and potentially cause obesity, lifestyle is probably the most commonly implicated mechanism. So the idea that people with mental illness have measurably and significantly worse lifestyles. So they're more likely to have substance use issues. They always have poorer diets, and they have significantly worse physical activity levels. So those things are you know, obvious ways of obesity being an outcome of mental illness. We also have metabolic syndromes, and the most common way this is related is with atypical antipsychotics. So that's a common thing. Most people know that the newer antipsychotics tend to put on weight with people and have several other impacts that can cause metabolic syndrome. This is well evidenced, and you can see changes in metabolism within the first 2 weeks after starting an atypical antipsychotic. But interestingly, there is also some evidence about people with psychosis who are antipsychotic naive. So they haven't started medication yet, and they've already got abnormal metabolisms, and some of them can be diagnosed with metabolic syndrome at that point. So there might be some interesting links there between the underlying and as Costa said, you know, there may be sort of hormonal relationships with the gut and psychosis, and obviously that's a big area. So you've probably seen some of the new treatments for mental illness, and in particular some psychotic illnesses with poo transplants. So they're starting to target the gut much more in psychiatry. Obviously, eating disorders are a mental illness that do affect people's weight, and some of those do lead to obesity. And finally, depression. So when someone's depressed, they're not functioning as well as normal, and they often have a sense of helplessness and hopelessness. So the idea that they can do anything to improve their health, and in particular their weight and trying to achieve a healthy weight, is something that feels beyond them, something they feel will never work, therefore it's hopeless, or that they don't have the skills themselves. So they might believe that other people could do it, but just not me, because I'm so rubbish. The second way that depression can affect weight loss is the general sense of lost motivation. So you might really want to do it, but you just find it's hard to get going, hard to make yourself do whatever has been asked of you by your dietitian, your exercise physiologist, your doctors. And it also goes the other way. So we know that obesity is a strong independent risk factor of mental illness. Various mechanisms have also been suggested. One is just the reduced function of someone who becomes very overweight. So anyone who has some form of limited function and therefore limited living is more likely to develop a mental illness. So if you're just doing less stuff, not living your life as well as you normally do, you're much more likely to become mentally unwell, and this flows through to other areas of reduced living that aren't health related. So that's a well-documented phenomenon. Then there's sort of more specific lifestyle factors. So perhaps your inability to work means that you have less money to go and have your mental illness treated. You might not be very mobile, so some of our more severely obese people can't leave their house. Those sort of lifestyle factors really tend to put treatment of mental illness at a much lower priority, and they can easily be impacted on by being very overweight or obese. And finally, as everyone before me has mentioned today, inflammation in obesity. And the inflammatory cytokines are highly implicated in particularly depression, but other mental illnesses. I believe Sarah did a PhD on it. Yeah. So they're very bidirectional, obesity and mental illness. They go back and forward. So where do you think, where would you start? Which should you treat first? No suggestion? All right. So the best evidence is both should be treated. So they should be concurrently treated. And this is where I think psychological interventions can be useful. Mental illness is the traditional home of psychological interventions, and obviously there's good evidence for both psychotherapeutic and pharmacotherapy in mental illness, but also in behaviour change. And there are a lot of behavioural aspects of obesity management. So we can talk about some behavioural treatments. This is obviously a bit of a dated picture of a therapy session. They don't let me lie down anymore. So, but yeah, there is a lot that a psychologist can do, and hopefully you'll have some more specific questions. But if you think about changes in diet or diet restriction, very low calorie diets, all of those sort of things, you don't do them in your consult room with the patient. Generally, that's something they go home and do themselves. Similarly, physical activity, they might come in for a gym class or a session occasionally, you know, sometimes even weekly, but a lot of the exercise you're going to require from them is something they have to go home and do themselves. And finally, the post-bariatric self-cares, all of the studies that look at self-cares following bariatric surgery find that they are a significant predictor of outcome. They're also things we ask the patients to do themselves. So we're talking behaviour, and this is what psychologists do, changing behaviour. And so the way you do that is very broad and very complex, and it's not something I can kind of tell you in 10, 15 minutes. But in general, you want to use strong evidence-based behavioural principles to get people to do the stuff. But also you have to use cognitive principles to get them to continue to do the behavioural ones. So it's kind of like walking, you know, you can take a step, you can take one big step and put in all these behavioural strategies, but if you don't bring the other leg through and get them wanting to do it, getting them overcoming whatever kind of barriers their head's giving them, they're not going to keep doing it. And, you know, you see people pushing down just the cognitive road or just the behavioural road, and it's kind of hard work because they're kind of hopping on one leg. So what you have to do is both. But how you do that is complex. So, yeah, if you've got specific questions, but, you know, I think it's interesting doing the multidisciplinary approach to things. So one of the nice things at work coming over to HMRI is, you know, I was speaking to someone who's a benchtop scientist here who I'm doing some work with, and as he got into it, he was saying to me, wow, you know, like the soft sciences, which is a bit offensive, but he said the soft sciences are actually really hard, and it can be hard. It's not magic, but it can be difficult, but it's worth doing. And the NHMRC agrees. So their best practice guidelines for management of people with or management of people with obesity and overweight. I've just pulled out the bits where they recommend psychological intervention. So they suggest, based on reviews, that all obesity management programs are multi-component, which includes physical, dietetic, and psychological input. And they're saying that it's AA level evidence that these are superior to singular interventions. And I think everyone agrees, and everyone's been saying that today. They're also saying that any particular weight management program should be supported by psychological intervention. So this is where you're going to manage both the mental health issues, which may be prohibitive to the weight management program you have, and you're also going to support whatever that program is using psychological principles to get people to do stuff, whatever that stuff may be. They also recommend monitoring and treatment of psychological distress, which really just means make sure they don't go back to having a mental illness, which we know can be prohibitive. And then after successful treatment, they recommend monitoring of psychosocial and behavioural factors after treatment, just as relapse prevention, basically. And that's another big part of any kind of psychological intervention, is building in relapse prevention. So that's pretty much it. Thank you. Like and subscribe. Do you want to do questions?
You can start here now, and I'll invite all the panel to come back up here, and we can now have some multidisciplinary panel discussion. I'd like to thank everyone today for a really interesting and fascinating discussion on the multidisciplinary team perspective, and I'd like to invite questions from the floor.
Thanks, everybody. I think we have a question for you. So in the Severe Asthma Clinic, we have, say, 60% of our population who are obese, 40% of those have BMI over 40, high rates of comorbidity, high prevalence of anxiety, depression, chronic oral corticosteroid use, high rates of osteoporosis, complex social situations, seeing multiple different disciplines for their different comorbidities. How do we manage the obesity in that population? They can't access private surgery. They can't afford the pharmacotherapies. They're physically inactive and are chronically breathless from their asthma as well as their obesity. What do we do?
So I just need to repeat that question, which was, for the online audience, quite lengthy, but basically the patients in a severe asthma clinic are very, very complex. They have a lot of comorbidities that interact, which make their management extremely difficult. And taking such a complex group of patients into account, how would we manage obesity in that population?
Thank you. I think that's a question we all ask, really, isn't it? And that's what we try to address in the Sweet Dreams project, to bring all those specialties and try and treat one of the underlying causes using a multidisciplinary group of people. And I think that was really successful. What do we do now? I think we need to continue to try and get a service together for that top of the pyramid that has severe complex obesity, because it's going to save money in the long run and save the health of those individual people. Since that project finished, I've been referring everybody to Sydney.
Peter Wolf?
Ben, how do I get people to do stuff?
So Peter wants to know how you get people to do stuff. That was the thing I was trying to say. It takes a while. So that there's a whole lot of ways, but there's general principles you could do today. The behavioural principles are generally easier to implement. So, I mean, behavioural principles like externalising. So not letting people just keep their plans of behaviour in their head. So having it written out, having a plan, then having that monitored. So monitoring is a big, it has a big impact. So having them bring back some form of monitoring of what their behaviour was. One of the difficulties that people in health have is they often measure outcome, but not behaviour. So one of the tricky things is trying to find a way of measuring behaviour. So for example, in diabetes, we look at HbA1c, but not often do we look at how many times they actually tested according to their glucometers, those sort of things. So looking for the behavioural measurement. People don't like that. That's another behavioural principle, right? Change requires discomfort. So don't be afraid to nicely make your patients a little bit uncomfortable. And so no one likes being monitored. No one likes handing over their glucometer if they haven't been measuring, but that's okay to still push for. So don't worry too much about discomfort. The other thing is making them feel like that plan that you've externalized and written down is something that they came up with themselves. So it has to feel like an individualized, tailored plan. In the end, most of them all look pretty similar. They're not that individualized, but making it feel like it is can improve the likelihood that the behavior is carried out. So there's a whole series of kind of principles like that are, you know, across the board, and I can't, you know, duck out by saying, oh, it's all context specific. The principles, the behavioral principles are always going to work. So that's probably something you could do today. Externalized, measurable plans that have some sort of feedback, and they need to know that they're going to be monitored. Yeah.
Okay, one here.
I just want to make a comment about access, because Vanessa's complex patients come in, super obese come in, they go through acute care, they go through rehab. You set them up with their plan, and it's an extensive stay, so they're there for several months. A lot of them are under NDIS. The last few have had to choose between psychology and physiotherapy. So they're set up to fail before they even leave.
So just for the online audience, that was a comment about access, where patients may only actually have access to one service, so they need to choose between physiotherapy or psychology, for example. So patients would be set up to fail from the beginning. So Steve, there's an online question.
So there's one question here that, so what are exercise options for this population, and specifically what exercise options when the exercise training for asthma obesity trial?
Okay. So there was a combination of aerobic and resistance training that we used, so 3 1-hour sessions per week. It was a mixture of intensities, so moderate to vigorous, just depending on the patient's abilities and preference. We are doing research now where we're comparing different intensities of aerobic exercise, so comparing moderate with vigorous intensity to see if one is a superior intensity to the other. We don't actually know yet. We haven't got the results of the study. So the research is still really quite vague when it comes to exercise in asthma. We're still sort of in its infancy and still sort of teasing through to find what is the best exercise training program for someone with asthma. We don't completely know yet.
Can you mention the increasing step counts as a start strategy?
And Lisa's just said as well, increasing step counts is also a good, easy strategy for someone who's just starting out, particularly, you know, if they are morbidly obese and have been inactive for a while. It's just a more gentle approach to getting activity levels up as well.
Well, Lisa, you had a question?
I had a question. So my question was for Costa, and I just wondered if you could explain a little bit more about the tsunami of revision surgery. So with the gastric sleeve, as I understand, you remove most of the stomach. So what's that operation to revise that?
Well, yeah, that's sort of field and evolution. Traditionally, the 2 reasons for revision with the sleeve gastrectomy are weight regain or severe reflux. And at the moment, we're sort of focused on the weight regain group, and traditionally we went to a Roux-en-Y gastric bypass. The long-term studies of that have shown that people don't actually lose any additional weight if they have a Roux-en-Y. So it's this concept of there's a fixed amount of weight that any individual can actually lose. And that's where they open themselves up to operators who will just do another operation because they still tick the boxes in terms of morbid obesity. So, but what we are increasingly appreciating is that Roux-en-Y, as we've understood it, is not a good operation for revision of a sleeve for weight regain. It's a very good operation for reflux control, and I'll say that again, if anyone needs an operation in the public sector, you can have an anti-reflux operation, which is a Roux-en-Y gastric bypass, and no health facility will have a problem with that at all, okay, and that's being done. So just wink, wink. Yeah. Yeah, that's right. Oh, good. Well, and I hope the administrators hear this, because the administrators we have in this hospital at the moment are willfully ignorant of the data on bariatric surgery and the benefits and quality of life and qualities. Okay, and they really need to have this put up in the press. This needs to be brought to political pressure on them, because it's just disgraceful. And frankly, I'm just sick of dealing with them, because you get the same willfully ignorant answers. I hope that's gone on the web. Yeah, so in terms of revisional surgery for the sleeve, it's not that the sleeve stretches, it's probably metabolic adaptation, it's probably various other factors that contribute. Sometimes the sleeve might stretch and that can be re-sleeved, but really doing some kind of malabsorptive surgery in the form of a duodenal switch, or bringing in some really distal bypass, does seem to improve their weight loss. But for reflux, a Roux-en-Y gastric bypass is a great operation.
I just wanted to follow up a question with Hayley in relation to the difference in the outcomes with the exercise interventions in the recent study in asthma, weight loss and asthma last year compared to your study. Why do you think they saw more success with the exercise group?
Yeah, so our combined group was similar to the weight loss, similar to the diet-induced intervention group alone. With our weight loss combined group, it was different in terms that those participants actually were instructed to have more calories per day on days where they were exercising. So it was sort of calorie matched to the dietary alone intervention group, whereas I'm assuming the study that was published in the Blue Journal last year wasn't they weren't instructed to have more calories, so they were able to lose more weight than the diet alone group. Does that make sense? We did actually also see losses in lean muscle mass in our diet alone group, so that was in line with what they saw, which we didn't see in the combined group. So that was in support of their body composition changes they saw. But in terms of the weight loss being similar across the groups, it would be because we increased calories on exercise days.
Any final questions?
On the theme of manipulating the system, how good is topiramate for weight loss?
We're just talking about the phentermine topiramate combination, and it seems quite effective and quite good. I haven't prescribed it or used it yet, but I think the results from the States are positive.
That's the combination.
That's the combination. Yeah, topiramate we routinely recommend in patients with epilepsy if it's a suitable alternative, because it does work a little bit, but we're talking about probably less than liraglutide. Phentermine alone maybe a little bit more than liraglutide, and the combination is even better.
There's actually pretty good evidence as an adjuvant therapy post-surgery in the plateau phase. And topiramate you can actually get on the PBS for 5325 for their terrible migraines.
Everyone is that.
Yeah. And you had 50 milligrams. I start them at 25 and go up to 75, and about 40% will have a good, they get about an extra 5%. But, side effects are a killer. Interestingly, the ones who actually had bad pain issues seem to do better with their weight loss than the ones who just had it for adjuvant weight loss.
Okay, so if there's no further questions, I'd like to ask you all to join me in thanking the wonderful multidisciplinary panel that we've had today. Resulted in some great discussion, and we'll see you at the next webinar. Thank you.